going to go ahead and get started because we have a lot of material that we want to cover today. But good morning and thank you for joining today's call. Please note today's training is being recorded. Questions may be submitted through the Q&A feature on Zoom, and we'll be monitoring it throughout the presentation today and sharing those questions with our facilitators so that they can try to respond to those during today's training. My name is Jennifer Hodson, and joining me are John Volpe and Rachel LaFlame. We're here with Health Management Associates, and Health Management Associates is a leading independent national research and consulting firm, and we focus on improving the administration and delivery of public health, healthcare, and social services programs. HMA is supporting the Mississippi Department of Mental Health in its efforts to enhance the state's crisis response system by providing monthly online crisis response trainings and monthly crisis provider convenings. Also joining us today is Jeff McCutcheon, the Chief of the Oxford Police. Please note that this meeting is open to the public and it is being recorded, so anything said or sent in the chat, which I think we're closing the chat, so you won't need to worry about that. This meeting will be part of public record, and we're closing the chat because we're really trying to funnel your questions through the Q&A. And thank you again for joining us today. Today's training module is Best Practices for Behavioral Health Crisis System Collaboration with Law Enforcement. And I will now pass it to John and Chief McCutcheon for a short introduction and your learning objectives. Have a great training.
Thank you, Jennifer. I'll go in first and then the chief can maybe introduce himself quickly. Yeah, I'm John Volpe I'm a consultant with HMA out of New York City. Lots of years in social services and then lots of years in the legal system in New York City, set up a justice office. And this is kind of my passion, is bringing together health and justice players to kind of really help improve outcomes for people. So I'm excited to partner with the chief on this. Chief, you have some opening words?
Yeah, I just want to tell everyone good morning. It's a really great opportunity to be here. I've been in law enforcement for 23 years. I've been the chief of Oxford for the last 6. This is a model that we've been using probably 5, almost 6 years, and we've seen the success. We've seen the ways that this can work and be successful. And it's not only impacted our community, but we've actually used it here in this office with our own staff. And it's an incredible asset when we all come together and collaborate. I think we get those outcomes that we're looking for, which is, being a blessing to those that we're here to serve.
Great, thanks, Chief. So quickly, the chief and I have a slide deck. Obviously, we're going to go through it. There's a couple of parts. We're going to try to get you involved. We hope you participate. There's some places where we're asking for your input through polls, and Rachel will kind of let us know how we're going to execute that. Not my specialty, but fun, hopefully, and important, and will give us a little insight into your thoughts and practices. Also, we do encourage you to give questions through the Q&A, and Rachel will let the chief and I know. And to the degree that we can address them, yes, we will. To the degree that we can't, then maybe there's some follow-up. This is only an hour. I said with the chief and I were talking, this is just like the tip of the iceberg. So hopefully stimulating, thought-provoking in some ways, reaffirming in others, but this should hopefully springboard you for future ongoing work, enhancing what you're already doing, or maybe kicking off work that you're not doing. So here you see our learning objectives. I'm not going to read them, but quickly, it's pretty much focused on, there's a lot of, to the left, the blue, there's a lot of common space that healthcare and civilian crisis workers were managed day to day, that police also do too, historically. So we want you to understand and look at and see what those are. And then kind of pivot to, well, are there opportunities where the work that you're managing on a day-to-day or even surveilling your crisis service system kind of reaches into both the behavioral health system and the public safety system? So that's the yellow. And then in the, I'm not good with colors, looks orange to me on the right. It's taking the foundation of those two and saying, great, So what do we do now? And I love it. The chief and I were on a call, and he's like, yeah, it's great, but now we got to move past problems and mitigate them, and we have to find solutions. And that's what he's done. I'm so excited to hear what kind of work he's doing. So we're gonna hopefully leave you with some thoughts about how you achieve better partnerships and collaboration. We can go to the next slide. So just to set the background, I think it's important to kind of know, obviously there's lots of history and we're being selective in what we're presenting, but there's a whole history around the work that the chief has done in policing and the work in health and behavioral health systems and services, including the part which is crisis, which we're talking about. But more recently, we've seen some of these trends or events which are informing today and this work. Things such as, the ongoing after COVID. I mean, I'm probably preaching to the choir here, but after COVID, lots of us, including even myself, I mean, it was just a jolting experience that impacted all of us in many ways, including our mental health. Um, and then even extending beyond that, technology and young people, and there's just waves of change in society which is impacting mental health in general. So we really need to be paying attention to that, as well as the ongoing um, tragic opioid crisis that continues to ebb and flow. Thank God we've seen in some places, drops in numbers of overdose deaths, but still a very important issue. There's also a better understanding of mental illness and substance use from 20, 25 years ago. I'm kind of an older timer, so I've been in the game for a while. Some of you may have, and you see is a very different world than 20, 25 years ago. There's also changing perspectives on law enforcement's role in addressing behavioral health issues. And I want to come back to that and ask the chief in a minute to just give his perspectives on that, because he and I were riffing a little bit about that on our planning calls. But I just want to, before I do so, point out the feds have gotten this and see the importance of this, and SAMHSA and American Rescue Plan and CMS together or collectively have either released guidances and or funding pushing states, counties, cities, and local jurisdictions to really think through how they address crisis. So we're going to reference some of those later, but I want to pivot back. Chief, thoughts on bullet 3 on changing perspectives from your perspective on the role of law enforcement on addressing behavioral health issues?
Yeah, I think there's been a huge change in that. When I got in, 23 years ago, essentially when law enforcement showed up, we had two options. We either took you to jail or there was nothing we could do. We didn't give you a whole lot of options. We were not trained on it either. And so it was either go to jail or nothing. And I think what we've seen over the past, again, 5, 6 years, we've seen this trend of looking and understanding when people are in crisis. And I think law enforcement is getting in a better place to where we're looking at humans as humans and showing up with a service mentality of how can I meet your need? What are you going through? What is the best outcome for this person? I think too often in law enforcement, we repeated behavior that didn't fix problems, and then we got frustrated because we continued to go back to the same calls. And finally, a model like this comes in and says, hey, there's a better outcome and there's a better way to solve these problems. So look at people in crisis. What can we do? How can we help with their mental health? What if it's an addictive issue? You find these partners, and this has been, our experience here locally, is we found partners that cared about people. Well, that was the same mission that we're on, is to care about people, meet them where they are, and then provide them with the best resources that we can. Doing that in a silo for us doesn't work. And I'm sure on the behavioral health side, you alone may need support from us. And so when we work together, you get that ultimate outcome of serving that person, that you're not repeating those calls or repeating those behaviors or seeing them continue to be in a crisis. So I think that's the biggest perspective change that I've seen over the last few years with us.
Great, thanks, Chief. And we'll be able to get more unpack that a little bit. And I love it's not new, but I love that you focus in on silos, because as a person who lived in the health system for many years, like we were siloed and we liked our silos. So it's not unique to law enforcement or other sectors. The health system can be siloed too. Next slide. So this is just a very high level, and the chief was just talking about silos. So this is like the essential elements of an integrated crisis care system. And at the top to the right, gets into the three key pillars that are often called out in the literature and SAMHSA's materials, and you're probably familiar with these. So it's 24/7 crisis call centers, so someone to call for help or someone to talk to. And then this should be reachable through a dedicated crisis line, not such as 988. The advent and rollout of 988 is an amazing change. But it also includes 911. You see them in the second bullet called out there. The second is the round the clock mobile crisis team responses. So this is someone to respond, people in the community doing direct interventions, and it's services to anyone, anywhere in the community. And you see an important second part of that is may include community responders or co-response with law enforcement or law enforcement more generally. And we're going to focus on this. Because there's a bit of a rub here about law enforcement, yes, law enforcement, no. And that's kind of can sometimes be vexing for jurisdictions, but the better that you plan and collaborate, you can kind of address those. But the third pillar is the short-term receiving and stabilization services for people. So this is a place to go as an alternative to really expensive, busy emergency departments or psychiatric centers. We want a kind of a much more community-based approach, low threshold, very warm and inviting for the person who's receiving it so it doesn't feel so institutional. And these have shown to be great success. Well, law enforcement plays a big role in those because often they are the source of referral to those. So those are three components, and law enforcement gets called out in each. To the left side are other critical elements: person-centered and strength-based, community response, and peer supports. You see law enforcement called out there as well as trauma. And Chief, I just wonder if you could comment a little bit on, in some jurisdictions I've worked, police have had a harder time engaging in these partnerships because they felt like they didn't want to give up kind of their role in the behavioral health crisis services, whereas kind of the move now is for more of a partnership. Do you have any, like back in there, you've been in the game for a while, so back in the early days, like any thoughts about that kind of tension that exists potentially in some police and health relationships?
Yeah, I think it goes back to human dynamics. When there's no relationship, there's a lot of mistrust, there's a lot of confusion. One side doesn't understand the challenges that the other side has, and so there's friction when we don't feel like that this landed the way that it should. And so I think on the front end we have to start working on relationships if they're not there, because they're not just going to be built overnight. Because these are very critical calls, these are very sensitive calls, and so there's a lot of passion on both sides. But when the relationships get built and the conversations are had of what each group's role is, and then how they can best benefit the other person. And honestly, it's speaking from the law enforcement side. When I understand from the behavioral health side how this helps us as an agency of, listen, we can get this person care where you're not repeatedly going back. Arresting them over and over and over doesn't solve the problem. It's going to keep reports, it's going to keep you responding. But if you can create a long-term plan that will help benefit this person, you're not going to those calls anymore. You're understanding, and then bam, on the next call, you're already starting this process. And so the quicker you can build the relationships and understand each side, I think the better shot you have to having a successful program.
Great. Thanks, Chief. Good insights there. We can go to the next slide. So hopefully this will be a little more interactive. These are the common behavioral health issues managed by both law enforcement and crisis providers. So as we were saying, like in the day-to-day, there's commonality in what both sides of this coin are doing. So I'm going to turn this over to Rachel in a second if there's anything. Oh, here she already put it up. So you can see on the slide, as well as a poll just popped up, and we would love you to participate in this poll. And it's basically, in your experience, what are the most common situations or case types, I'm sorry, that law enforcement and crisis providers commonly manage in their daily work. So select two. And I'm going to give everyone some time for this. Wow, real-time tabulation here. This is pretty exciting. Looks like we're kind of settled there, Rachel. What do you think? Another couple of seconds, 30 seconds? I don't want anyone to. Any last calls? Okay, let's call it. So you can keep putting it in, I imagine. But so here you can see lots of responses around commonly managing mental health crisis, substance use incidents, domestic violence situations, homeless, very relevant today, homeless related concerns, welfare checks, which is often typically a thing in the public safety and law enforcement world, but mobile crisis might be called out to help and assist with that. And then around the issue of suicide. So you can see here that there's a significant overlap between law enforcement and crisis providers in types of situations or people's issues that they're addressing. So thank you for participating in that. We can go to the next slide. So Chief, before we get into this one, do you have thoughts on, and I'm going to put you on the spot, don't kill me, but percentage wise, how many of your jobs would you say there's some behavioral health issue going on? Like, and if you know it generally, would you ballpark even?
Yeah, I mean, I would say a high volume. I mean, possibly 70%. When you think about everything that we deal with, there's some type of trigger. If I'm getting called, there's either a health crisis or behavioral crisis. So at some point, those all do overlap. I'd say it's an overwhelming majority.
Yeah, yeah, and that's very consistent with the work that I've done across the country. So I'm just glad that we can just have people, if they don't understand the level of behavioral health issues that law enforcement actually manages, even if it's not the primary issue why you're getting involved. So it might be, a low level offense that's related to someone's, crisis, like a crisis in their life around food or housing or whatever, and you guys get involved, but behind the behavior is lots of complexity. So I just feel like more reason for partnership because you all on the health side can see that here is the common intersections that we pulled out on this slide. There's others, but 988 911. So we already talked about this, but 911 is getting plenty of calls that are behavioral health crisis related or from situations where behavioral health is a big issue. Obviously, behavioral health crisis. During an enforcement and arrest, I just gave an example of situation where person might have, be having a behavior that results in kind of an infraction or a violation of the law, but actually behind it is lots of complexities. So, and I've seen cops really wade right through it sometimes and be able to really pinpoint that, which is amazing when they can do that. Homelessness, huge issue, but homeless response, I'm not sure, Chief, if you guys have a homeless focus, but in like some bigger jurisdictions, Like we have units that are dedicated in New York City to homelessness. Well, it almost seems incumbent to me that we have to partner with the health, because if you're dealing with a homeless issue, the police are just not going to have the tools. We talked about the welfare checks. Reason I put that on there sometimes is a lot of times behind the welfare check or the request for those where cop, could you go out and check on my loved one? There's issues going on that police may encounter that aren't really in their bandwidth or their skill level to manage. So they may be calling you and doing some warm handoffs, and we'll get to that. Warrants can be areas where police are working, where there can be nexus to someone who's having a mental health crisis or substance use related crisis. Transportation, I know for the chief, we talked a little bit about this. This is a big issue across the country. I'm not sure if Mississippi is, having issues, but there's real issues around transporting individuals who do need in crisis to an ED or a crisis stabilization, and trying to do it in a way that is least restrictive. So, Chief, I don't know if you have any other thoughts on these common intersections before we move on.
No, I think sometimes though we do, we talked about silos earlier of enforcement and arrest and how that may times where we think that doesn't really cross over to the behavioral health side, but it really does. If we're making an arrest and we can get some type of information on that individual, we need to know, are there issues in their life that causes them to be in a crisis state? And if those are triggers, then I don't want to do that when our team shows up. We don't want to approach in a way that's going to escalate a situation. So when you have that great conversation with your behavioral health providers, it helps us deal with arrests better. It helps us serve warrants better. And I'll tell you where it's really been beneficial is welfare checks. Sometimes we can take for granted if someone calls us and says, "Hey, you need to do a welfare check on my family member." A uniformed cop showing up beating on a door may be the worst thing that could happen there. But if I don't know that, I'm just trained that's traditionally how we do it. But when we have those good relationships, we can call and say, "Hey, I'm headed to this house. Do you have any background for me that you can share that I can better do this?" And there's times where communicators called us and said, "Hey, y'all don't go. We're going to go. You just be in the area if we need you, because if you show up, it may make it worse." Awesome. That person is safer, we're safer, and it's all because of a collaborative effort.
Yeah, it's amazing. And actually, my note was I wanted to make sure you talked about silos because you mentioned it earlier in the week, and you said to me, which was powerful, like we're all doing this, but a lot of times it's in silos. So if you could reduce the silos, really important. Yeah, next slide. So now we want to like kind of start to build here and go to partnerships and collaboration best practices between law enforcement and crisis providers. Um, and this has been variable in different places. Clearly, the chief, where and his department has great relationships with their health providers in their area. That's not always the case. I've worked in places where the collaboration is close to non-existent when you start to really talk through with them, which is okay too. It's just hopefully this kind of exercise is food for thought to maybe springboard much more discussion around how you can collaborate. So here is our second poll. In your experience, what are the most common challenges law enforcement and crisis providers face when collaborating? And we give you some um, some common examples, but I think there's a place maybe you can give us other, but if you can't do other, you can always put it in the Q&A and Rachel could read those out if there's others that you want to highlight. And we'll give this one a little bit of time. seems to be slowing down. I just, if anyone does see another, have another one and they want to shoot it in the Q&A to Rachel, feel free, just take a minute and do that now. I would love to hear other ones too. If we had more time, if this was longer exercise, we would do maybe some breakout groups and talk it through, but that's something maybe you do in the future. You focus an hour session on this alone. This is critically important. So here you could see moving a little bit still, but communication breakdowns, um, critical, right? And then I think when I was looking at this, differing protocols and procedures, like very critical, which could actually also be maybe solved for or partly solved for communication breakdowns, as well as the lack of shared training. It's just amazing that people are pinpointing that. Um, Limited resources and staffing, we get it. It's a big issue. Workforce is big on both sides, public safety and health. Um, I was interested to see the data sharing barriers are less because usually people, you know, are very, very focused on data sharing barriers. I think it's critically important. We're going to talk a little bit later. And then cultural and philosophical differences. I think that's a really important one that in your planning, if you can work together to understand the culture, roles, and expectations that your partner has. Like, what is their role? Like, and appreciating that and really respecting it, even if it doesn't jive totally with your mission culture. So that's going to be critical for you to move forward the relationship. Chief, you have any thoughts on the outcomes here?
Yeah, I was pretty intrigued that four of those are very similar from the percentage, and but it's true. I mean, communication breakdown is at the top, and then because we don't always understand those protocols, the training isn't always there, and that limited resources and staffing is a critical piece because that can sometimes be where we get off with each other because we get frustrated because the outcome didn't hit or that this partner couldn't come through. But if I know what challenges that the team faces in the field and we don't get that outcome, then we can work to a positive resolution on the back end, which goes all the way back to number one. It's just we got to communicate and build that relationship.
Agreed, agreed. Great. Next slide. Anything, Rachel, in the Q&A? No? Good, okay. So we are now common behavioral health crisis provider law enforcement partnership challenges. So you all obviously hit on a lot of these. The one thing I will say is just take a minute here and think of that time where you faced one of these maybe you were somehow involved in a situation with behavioral health crisis, and just give it a thought about what was the issue, how it resolved itself, and if maybe future planning was needed uh, to address so that it doesn't happen again. And my brain always goes to like data and information sharing, or even the duplication of services. Like Chief has been talking a lot about silos. So has there been times where you're kind of stepping on each other a little bit unnecessarily? So just this is great, hopefully, to help really put a frame around how you would have future conversations and planning. Next slide. So we put this in because what are some of the consequences of not planning and collaborating? So what are some of the outcomes? And I'll go right to the middle row, the top and the bottom gray. Um, you know, Probably most importantly, the person isn't getting what they need. And then the health side sees them in different places, homeless shelters, homelessness, ED. Police see them in different places. Maybe you see them together, but you keep seeing them is the point, right? So we're not meeting need. And if we're not meeting need, then we need to do something different. And the bottom gray gets to that also, right? The poor health, or generally from like a health of a community perspective, it's just not as healthy as could be because we're not really delivering the service that needs to happen. So, and then that can actually have cascading impact on public safety outcomes. So, and the reason I want to frame the two gray are later we're going to talk about a system level and a case or a person level, and collaboration and partnership should be happening across those two domains. And these two actually hit on them. Other things, as you have bad outcomes, this happens in many sectors, hospital systems, wherever, you start to build mistrust and misunderstanding, deep misunderstanding of others when things aren't going well. You could poorly use resources. I don't know about all you, but money's tight in many places. We need to be better with our resources as our economic turmoil continues. So we need to make sure our resources are being used well. And then in the left, the blue is also unnecessary use of arrest and detention and potentially hospitalization. We don't want to see that for many reasons. Costly, destructive, and really doesn't help people in the long run. Yes, do people need hospitalization? Yes, they do. But let's make sure it's an appropriate use. Do people need incarceration? Sure, they do. Certain people do need to be taken out of the community for safety reasons, but many do not. So we can see that there's real consequences to not planning and collaborating. Chief, any thoughts here?
Yeah, just one where you see overuse of public safety resources. I just want to encourage our partners on here. You might hear that from your local law enforcement of, hey, that's a medical side, that's a mental health side. Y'all need to do you, we'll do the public safety. And here's the thing I want to remind all of our law enforcement folks, and you shared this with them, we're going to get the first call. We're going to be the first responders when there's an active attack, when there's a critical incident that happens. And I think you can walk many of those situations back to there was a behavioral health issue. So I would much rather use my resources on the front end to get better outcomes rather than saying, hey, this is just a behavioral health issue. And then we deal with that critical event on the back end. I would rather deal with it when it's small, not when it's great. And when we partner together, we have a chance to intercept that before it. But there's going to be a public safety issue. I'd much rather deal with it on the smaller end.
Great thought. Yeah. Next slide, please. So this is kind of, visiting the three key crisis system points. We're not going to belabor this. Someone to talk to, someone to respond, somewhere to go. It's just very good for grounding us in our planning. Keep those pillars in mind. Obviously, there's lots that go into each, but we're not going to dwell on this. You have probably resources from SAMHSA and others explaining the three pillars, and we reference them in our the end of this deck, which you'll get, and you can peruse those on your own. But we're going to go through each of the three key pillars. Next slide. So first is collaboration at the crisis center level, someone to talk to. And to the right is this 988 convening playbook, which is meant as a guide and support to plan around 988. And there's also a playbook that addresses like the interoperability between 988 and 911, which is really what we're getting at here. Obviously, there's lots of work that goes into 988. It's a tremendous transformation, but pulled this quote or this reference from the document. The establishment of 988 represents once in a lifetime opportunity to strengthen lifeline and transform behavioral health crisis care system in the US. The overarching goal is transformational, saving lives, serving anyone, anywhere, anytime. And then in a manner that minimizes law enforcement involvement and promotes linkages to ongoing local supports. Seems to make sense. But what I want to just point out there is one, historical over-reliance on police is called out in all these documents and in the literature, and I think the chief could probably talk about it from his earlier days. Typically, we over-relied on police to manage behavioral health crisis because the health systems weren't really stood up and equipped to do so, generally speaking. So now we're seeing a shift. So that is a shift. but it doesn't mean that law enforcement plays no role. I think we've tried to drill that home today, and that partnership is critical. And the last thing I'm going to say is when you're unsure or when you think there is a safety issue, you do involve law enforcement. And I see the chief shaking his head, so I'm going to turn it to him to just drive that point home.
Yeah, 988 is a beautiful model for triage on who needs to respond. But if there's any question, let us go with you. Even if you say just stand by in the wings, but that's what we're here for. That's our job. That's to make sure everybody's safe. So if you're not 100% sure you don't need us, bring us with you.
Great, Chief. Next slide. So here we just look at what's the goal? So the goal is a cohesive approach, no wrong door system where calls for assistance can be transferred seamlessly after risk and need are determined. What does all that mean? Well, 911 is getting calls, text, chats potentially, and they're going to do some assessment. And if they determine it's a behavioral health crisis that is a lower risk, or they think it could be managed by 988, well, they should have a pathway to send it. And vice versa. 988 is going to get calls where they go, whoa, we done our risk assessment, risk and need assessment, and this one seems like it might need an immediate police response. This might, I'm just going to throw a dramatic one out, hostage or weapons, or that one needs to go to 911. Well, you need a pathway to get it there. So that's the interoperability. This is a big lift. There's all kinds of issues to get this to be really highly functioning and well integrated. But see, we pull out some key elements: policies and cross training, interoperability, which you work toward. Police systems, PSAPs typically use CAD systems. A 988 could use a different system. They have to talk to each other potentially, but you can find workarounds. Risk assessments is a big deal. But this is where you can plan. And then what does that lead to? You want to dispatch the right team. So you need to be able to do an assessment of risk and need. And you need to be able to communicate so that the party that dispatches the right response is able to do it. Next slide. On this slide, we just get a little more into the risk assessment tools. And to the right, we point out language is different. The way you do risk assessments is different. I'd love to see when you take a 988 center and the 911 center and you pull their scripts and look at them. What do they ask? Sometimes they're very different. The nomenclature is different. So you see, this begs for planning. But when you do it right, you can identify and discuss and codify role. This is the bottom square. You can identify, discuss, and codify the roles and responsibilities for each party, including how are we going to assess for risk and need, and then how are we going to share or transfer people who could be better served by the other partner. Or maybe it's both partners, but you have to work out those protocols. Any thoughts here, Chief?
No, we don't. So we don't operate with the 911 center. But again, I mean, we need both parties talking, like you said, on that same plan, because if the law enforcement side gives misinformation or poor information, then we don't get that outcome we want. And I think that goes all the way back again to everything everyone has said so far is just communicate and collaborate.
Yeah. On the next slide, which I'm going to go real quickly, you'll get this, is LA put together a kind of a framework for their 911 to assess calls. Now, this doesn't give you their script of what they're asking, but it allows them then to give a score, which would be a guidance for the call taker to potentially then say, this one might be able to go over to the 988, or this one stays with us. So check this out when you get this. It might be a helpful resource. Next slide. Then we get to someone to respond, and SAMHSA has put out a whole guideline, and you see it to the right there, National Guidelines for Behavioral Health, Best Practice Toolkit. And we just pulled out a couple of these quotes here saying how the push is to stand up on the non-law enforcement side, crisis services, so that law enforcement can kind of fall back into a more appropriate role from the historical over-reliance. So you see the last one, avoiding unnecessary law enforcement involvement. We do not want to use really important, critical, limited resources in public safety to manage things that are much, much more routine and can be managed in the healthcare system, in the behavioral health crisis system. So we need to plan at the response level. Next slide. So what are we shooting for? A balanced approach for determining who should respond to a behavioral health crisis based on training and skill of the responder, as well as the needs and risks of the person. And again, not comprehensive, but pulled out some key elements. Respond with law enforcement when possible, unless special safety concerns warrant inclusion. And the chief said this, when in doubt, be safe, right? At least reach out. If you have a pathway to the chief, hey, chief, what do you think? Like, what are your thoughts? Be safe. Be safe for yourself. Be safe for the community. But that then calls out, have real policies and protocols to talk about warm handoffs between law enforcement and behavioral health crisis providers. The same could be for a young cop on the job and he's out in the community and he comes across John and he's like, I don't know what to do with this person. This is out of me. Maybe there's a way that he can pick up the phone and call a clinician, call someone, call the partner at the health system, health crisis system, and get some input. Cross training, you guys honed in on this. We need to train both sides to understand these issues. And what I did in New York, we did was safety training for mobile teams. The cops actually taught, why do we stand the way we stand? It's more strategic for safety reasons. Well, I never knew that. My clinicians never knew that. Well, then that helped us be more safe from a tactical standpoint, as well as using our clinical skills. So I really, really encourage the planning around this like response level to be a primary focus. Information sharing at the case level, and then establishing transport policies. Any thoughts here, Chief?
No, sir, I think you covered it.
Cool. Next. This is just a framework. We're not going to dwell on this either, but this is a framework where you can see there's a continuum. This isn't saying police are no longer involved in behavioral health crisis. It's not saying police are doing all behavioral health in crisis. It's saying there's a continuum. This is consistent with the LA model but that's at the call level. This is at the response level. To the left, you see 1 and 2 might be scenarios where mobile crisis can go out on their own. 3 and 4 might be some joint responses needed. And that might be co-response if you have that. It may be just mobile crisis and cops coordinating to actually manage the situation together, but in a kind of not in a co-response, in a dual response model. And then there's clearly situations where law enforcement has to be the responder, hostage, weapons, and there's all kinds of things where safety is called out. Any thoughts, Chief?
No, sir.
Okay, so then we move to collaboration at the crisis receiving and stabilization level. So we've managed the call, we've responded, and now the person needs some additional stabilization. They need a good place to go. And these crisis receiving and stabilization centers I love these. They're near and dear to my heart. I think that when these operate well, and police is a critical partner in making these work, I've just seen really amazing things happen for people. It offers a place, there's no wrong door. They can address behavioral health and other issues. It's operating like an ED in some levels, but it's much more low threshold and welcoming if done in a certain way. You see the key elements. The top 3 are minimum, officer drop off, and these are focused, the ones we pulled on law enforcement. Be structured in a way that you can accept all referrals, meaning no rejection. You can't have really picky inclusion criteria. That said, there are times when you need to send someone elsewhere. You build those out in your policies and procedures. You don't want medical clearance prior to these because that's going to defeat the purpose and push the cops to the ED, which creates another whole issue. Best practice to operate 24/7 and offer a dedicated first responder drop-off area. And then you see other recommended elements of these are develop your policies and procedures with cops. Make it really rapid turnaround for cops. They can't get caught up for hours and hours doing paperwork and things. They need to get back out onto the job. So you want a really quick turnaround, and there's places that have done this well. I've been working with lots of them to build, real quick turnarounds. Cross training, we've been talking about that in data. So a lot of the elements, data sharing, cross training, they go through all three pillars of the crisis continuum. Next slide. So we have a participant poll. We want you to, for three areas, we want you to rate your local jurisdiction in terms of how is partnership and collaboration at the someone to talk to level, the someone to respond level, and a place to go level. And it's okay if you're choosing something like it could improve, meaning C, D, or E, or even B. It's totally okay. It's a baseline for starting and planning your future collaboration.
In the interest of time, I will go to the next slide, but I will keep the poll open. So please take a moment and respond. And if we have time at the end, I will put the results on the screen. Thank you so much, everyone.
You're amazing, Rachel. That's a great idea, because what we're getting into, and you can drone me out. If I'm droning, you can just don't listen to me and keep doing the poll. But this is exactly what we're talking about. We want collaboration to build comprehensive integrated crisis systems. That includes collaboration at the system level, cross-partner systems getting together, deciding how to work together at a system level, and the point of care. And what does the point of care mean, or point of response? Well, we just went through it. The chief has a young officer out on the street, and he comes across someone who's in a behavioral health crisis. Well, he may potentially want to enlist a mobile crisis team to come out, or a crisis provider. How does he do that? You need to work out all the protocols and policies. You need to do all the training. You need to have the data sharing. So that's at the system, the response level. Then that gets tracked. Then when you do a meeting quarterly, monthly of your leadership, looking at your dashboard potentially, and I'm throwing things out there as ideas, you might say, hey, these are our BH responses. How did we do? You might do some retrospective. Where do we need to change? Where do we need to tweak? How are we doing? Are our familiar people who keep cycling reducing their cycling? So at a system level, a surveillance level, like public health is very used to surveillance of public health. Cops do CompStat. You can build those into a crisis system oversight, as well as and in addition to being informed by all the responses that are happening on the street. So I really encourage a dual focus response. Rachel, do we have like final polls, or are they still jumping?
The majority have responded. I'll keep it open, but looks like we have some results.
Okay. You just tell me when you think we're ready to share. We can go to the next slide. So here's some questions while we're waiting for the election results to come in. Hopefully it's not days. Who are the right law enforcement and behavioral health partners to lead this work? You need liaisons, champions. The chief is a champion. Like, I would put him on that list. He's fighting for this partnership. He's working hard. What's just good ones to point out? Have you done any mapping? It's at the bottom. Like, some places have done crisis mapping, or they've done sequential intercept mapping. Can that be used to inform your future work? The other bullet I want to pull out is there already an existing, it's number 4, cross-system work group or steering committee that you can use to fold BH crisis into? Like if you're doing a jail and reentry work across partners, maybe you do a sub work group rather than creating a whole new apparatus. So I'm trying to give you ideas that other jurisdictions have used to maximize their time rather than duplicating. And then the last is agreements. Do you want to codify these agreements? The chief will retire at some point. You guys will all retire. When people move on and champions move on, sometimes these things lag, so you might want to codify them. Any
Hey,
thoughts?
John, just one thought too, where it talks about your law enforcement partners or those liaisons, who are those best contacts? Let's assume that I'm not an advocate of this program as the chief. Somebody in our organization has my ear, has a little influence within the department. If you think your local sheriff or chief is not going to be a proponent for this, figure out who that person listens to, spend time with them, build that relationship, see if they can use their influence to get this thing lifted. Because again, it is an amazing system when we all work together, and it truly meets both our needs of getting the outcomes we're looking for.
Great point. Great point, Chief. Next slide. So we just gave you some ideas for action plans for implementing partnership meetings. I'm not going to, we don't go through this. You'll get these. Hopefully this is a guide. I've worked with lots of jurisdictions, developing like a toolkit for guiding these relationships over time. But these are some of the key elements. Commit to meeting, establish a culture of problem solving, don't avoid blame. One of the things I wanted to point out here is I remember doing work in New York City, and it's not like the health department and the NYPD always agreed. And I love it. What sometimes my police partners would say, let's just start with where we can find a common ground. Where is our North Star that we both can work toward? And then what I found is you work and solve on one little area, then they say, hey, you know what, John, we also want to talk to you about homeless problem or some other. It's like, oh, great. Okay. So to the chief's point about you need to find the champion, use other champions, but also make the problem smaller potentially and tackle it together. And that can then grow through trust and understanding versus mistrust and misunderstanding. Next slide. Moving forward, when to use 911 versus 988, law enforcement role in least restrictive alternatives. So I think the chief's already said this. He doesn't want to lock people up over and over. Can we find alternatives? If it's an alternative to putting someone in the jail for a while, maybe it's a CSU. Alternatives to law enforcement transport may not be an option for you all now, but down the road, maybe. Focus on familiar faces, high utilizers. I've seen amazing partnerships around those individuals who continue to show up in both sectors. Telehealth and video to connect law enforcement with clinicians or mobile crisis providers might be an option. Can't always co-respond, or you can't always joint respond. So maybe it's using technology. And then information sharing and policies and practices. Just really keep those top of mind when you're doing your planning. And then the next slide is just around sustaining some ideas for sustaining this work. Again, I think one of the and you'll get this, the critical one is codify it if you can. A lot of people, when you say, oh, we're going to do an MOU or like a charter, get really nervous about it. Doesn't have to be fancy, but people move on, environments change, politics change. If things are laid out in a written agreement, it's not like you can't change it, but it's a blueprint for future, people who take over this mantle to use to know what happened in the past so they don't have to recreate. Any thoughts about these last couple slides, Chief, before we go to the poll?
No, sir.
Okay. Rachel, I think if we have poll results, we're done with the slides. Yeah, we have references here. And then we have, I think, so you'll get these. And so partnership collaboration at the someone, so the 911988 looks like it's a heavy mix between excellent, good, and fair. So okay, a little bit pretty evenly spread between those. Seems like jurisdictions are doing work. Good for you guys. Like very much less in the inconsistent ad hoc or none. So that's encouraging, but keep it up. In the second one, someone to respond. A little bit heavier on the good, but still pretty evenly distributed between excellent, good, and fair, but still work to be done there. And then on the a place to go, a little bit more shifted toward the middle, the bulge in the middle, but still very encouraging because it looks like y'all are really you're talking. Like there's not a tremendous response around inconsistent or ad hoc. I think this is the highest inconsistent or ad hoc around this place to go that I'm seeing at 19%, but very encouraging. And I am going to turn it back to my colleague, Jennifer, who's going to bring us home. And we really do, next slide, we really thank you for participating. Feel free to reach out to me or my colleagues at HMA or the chief if I'm offering them up, but if you have questions. Jennifer.
It was excellent. Thank you so much. And thank you, Chief and John, for all the expertise and for the audience for really giving us a good sense of where you're at with this topic. We wanted to share the next Crisis Partners convening is on August 27th at 10 a.m. This is a space to connect, hear from crisis partners throughout the state, and share best practices. We also would love for you to check the DMH website for on convenings, training sessions, and new training uploads like the one today so that you can continue to access it, refresh, and also share it with other colleagues who weren't able to attend. And lastly, as we close out today, we really wanted to encourage everybody, if you'd like to stay up to date on training offerings and events, please take a moment to follow DMH on social media. And on the next slide, we have some of the places where you can visit. And those are some of our upcoming topics. There you go. Well, thank you again for joining us and have a great day.